The idea of this project was really driven largely by Dr. Gupta, who was seeing patients with urothelial cancer in her practice and was noting that many had significant personal or family histories of cancer. However, there were really limited guidelines for when germline genetic testing should be pursued for patients with these cancer types. And that, led to a collaboration between her and myself and the genetic counseling team to look into this issue further. And we did that by using the Orion Avatar program. Orion is a network of cancer centers that enrolls cancer patients in a centralized protocol. And the Avatar project is one of their main initiatives, which is conducting whole exome sequencing of germline and tumor. And this provided a really diverse data set of patients who were not selected for being high risk, but enrolled prospectively in this program, and was an excellent source of data for looking at this issue of factors that might help predict which urothelial cancer patients may have underlying germline pathogenic variants. Dr. Gupta?
Thanks, Wendy. We know that aging, smoking, and other carcinogenic exposures are the biggest risk factors for urothelial cancer. We also know that there is a familial component, which could be partly due to shared environmental risks or partly due to genetic predisposition. We have accumulated published evidence in select populations with urothelial cancers that have identified germline variants in anywhere from 11 to 24% of patients. And majority of the studies have shown a greater prevalence of homologous recombination repair genes as compared to mismatched repair genes, which are classical for Lynch syndrome. Current guidelines support evaluating genetic risks in patients who present at a younger age or have a risk of Lynch syndrome. But we're not sure that these are adequate to identify patients with inherited cancer syndromes. So the main aim of our study was to identify clinical features that are associated with inherited cancer predisposition syndromes in urothelial cancer patients. We decided to look at the Orion dataset because these patients were not selected based on inherited risk of disease. These were patients who represent an unselected real-world patient population presenting to various US cancer institutes with a diagnosis of urothelial cancer.
Yeah, well, we had as Dr. Gupta explained, through the Orion data set, we had access to patients who had confirmed diagnoses of urothelial cancer, and also had completed germline exome sequencing. This was research grade exome sequencing, as well as molecular testing of their tumor. So we selected patients who had these complete data sets. And the goal was then to compare those who had germline pathogenic variants to those who did not, in order to identify factors that may be predicted having a germline or that were associated with having a germline variant. And, this is where, there was a lot of decision making in our design on that in terms of what we are classifying as a pathogenic variant. And while we had access to exome sequencing data, which obviously could identify many different types of genetic variants, we really focused our analyses on individuals who had known pathogenic variants in genes that are associated with an increased cancer risk in heterozygotes. So, we focused on genes that were known to cause a clinically actionable increased risk of cancer, and variants that were already classified as pathogenic in ClinVar. We have further analyses planned to look at more novel associations, but for the purpose of this analysis, in order to ensure that we are really focusing on variants that that, at least had some established connection with cancer risk, we did have this very stringent criteria. And that was our basis of defining the two groups for comparison.
We selected those patients that had a diagnosis of urothelial cancer and had germline genomic data available. We looked at various clinical factors and disease features to identify which of these were associated with inherited risk. We felt that if we could identify factors that are associated with inherited cancer syndromes, it would help us identify patients at risk who needed to be tested in the clinic. After we identified the patients who had these pathogenic germline variants, we looked at their clinical characteristics and tumor characteristics. Due to the nature of the data we had, there were several pieces of information available to us, such as the primary site of disease, the age at diagnosis, stage at diagnosis, and so on. And so we were able to analyze that information as well as some tumor genomic data. And we were able to assess features such as microsatellite instability, loss of heterozygosity, tumor mutational burden. And we were even able to perform cluster classification in some tumors that had RNA-seq data available.